specification, I invite Dr. Rupa Vinokumaran, concerning communication of article leaving no one behind, inclusion of marginalized people in the society.
So I will be talking about the situation, about the marginalized community, the current legacy that we are planning, the challenges that we encounter, and the way forward that we want to move on. When we come to this data, as you can see, we are having a population of nearly 1.7 million, with a number of emerging areas, 31, should be considered as 31. And number of tests and institutions nearly 100, which is, I think, the largest RDHS which has highest number of tests and institutions. With that, this is about the prevalence of leprosy cases from 2016 to 2025 for the first quarter. As you can see, the numbers are getting reviewed along with the charity. So we go to the quarter 3 data this year. We have altogether 55 patients in nationally diagnosed with patients with a type 3 type 2. And again, we do have a breakthrough deformity presentation to be higher than 18%, with a recording of 3 as well as a relative status of 3. So this is the pattern of disease with the relative cases for the past 3 or 5 years. And with that, I would like to mention about the highly area has identified that is focused on the final list, granular, final, as well as division. So these are the marginalized communities in our district, marginalized tribes, or the tissue community, migratory service providers, fishermen, and the gardeners. Here we focus more on the marginalized tribes or the tissue community in Kunnara district. Regarding the distribution of tissue communities in Kunnara district, as you can see, they are mainly focused on 4 remote areas that are among the political and social race. I would like to mention about one particular thing that the people who live in these remote areas, they are interconnected. Usually the marriages and all the things happen within their community. So it is the one reason where the diseases more areas among their community. And this is one particular remote area, there are political remote area. As you can see, the number of cases are getting bigger. We have detected quite a number of cases from the political remote area as well as from the Kuru Battle or the Naya area GM division. This is about the political community. They believe that there is some people Basaran. However, they are not considered as high society group. They are being marginalized. Because of the community engaging in mobile training activities, as well as they do some kind of conservation, free service provisions such as carpenters, construction workers, and archaeology as well as ritual practices are being done by their community. The challenges we face in controlling the leprosy among these group or the victim community, the main one was the lack of optimal health literacy and misconception. Many people still believe method is highly contagious and incurable, even though it is incurable. Delayed appearance of symptoms and signs make it difficult to get down for the screening, and again, health is less priority in their life agenda. So that is another challenge where we have faced when we try to provide the literacy as well as when we are going to get the misconception. And here comes the stigma. The stigma when it comes to this community, anticipated stigma. So the stigma due to fear of societal attitude is mainly found around this. Physical deformities or disabilities, for example, skin, loss of teeth, facial deformities, created fear of infection to others, and that makes them social distance from each other. And I think that the internalized stigma, where they have the guilt of challenges which lead them to make themselves alone. Many avoid contact with persons affected by leprosy due to false beliefs about transmission, even though the disease is not sterile, so casual contact. So when we come to the employment of the community, particularly they are not other people and they are to the daily basis, it is a challenge again to capture these people and to lead them for the medicine, healing and treatment activities. Again, limited access to health service also has been a challenge because particularly these areas the therapies are not available. So to meet the therapies, they need to travel around distance, and the high transportation cost again make it a real challenge in their life. So what have we done for these challenges so far? We have conducted house-to-house active case surveillance in these identified areas, and this is the way that we have identified cases. You can see that number of confirmed cases are there with this house-to-house survey. And again, regular awareness programs to the community. This is not involvement of community leaders, sensitivity programs for medical officers, supporting the children with the leprosy appearance for their school supply, as well as conducting mobile hospital clinics and other activities that we have done to mitigate the challenges. Some of the pictures of the activities that we have done so far in the area. And moving forward, we need to improve the health literacy among these groups. The local community leaders are encouraged to conduct culturally appropriate programs because they are active, they have gained trust in their community. And stigma reduction involving respected, successfully treated individuals as local plans to the community for stigma reduction and awareness campaigns are being planned to utilize. And conducting satellite clinics which should be handled for the teaching hospitals who will handle the dermatologists because they agreed upon to do the satellite clinics for these people, and again identify recognized individuals in the community to assess total funds. The suspected individuals can treat them to seek the medical advice, but sometimes they themselves move along rather than they move with the care workers. And including the quality of life of the leprosy families, these support with the aid of government as well as non-governmental organizations. So finally, I would like to say, ECD is beginning to recognize in this market. Thank you.
Next, to talk to us about strengthening leprosy surveillance and control through a package of innovative strategies to facilitate service delivery. We have two speakers, Dr. Nihara Mansur and Dr. Rekhanjali Singh, who are medical officers at the Regional Director Health Services Office in Colombo. First of all, I would like to invite Dr. Nihara Mansur to the podium, please.
morning, everyone. On behalf of my team at RDHS Colombo, today we will be presenting our initiative in strengthening reference surveillance and control through a package of innovative strategies to facilitate service delivery in RDHS Colombo. Moving on to the introduction, RDHS Colombo comprises of approximately 1.8 million of population across 90 remote areas. As you can see in the round, this is the map of Colombo RDHS area, in which in 2024 there were 169 reference stations reported from RDHS Colombo, which is relatively low compared to the previous year. With that in mind, we had launched multiple initiatives to make our service deliver stronger. Our aim was to release existing legacy control services to plan and implement a package of services to facilitate the service delivery in the district. In our method view, we started off with a SWOT analysis with the participation of supervisory teams of all MOH areas. After which, we identified needs and went on to prioritizing them accordingly and developed different tools to address these particular areas that needed improvement. During our SWOT analysis, these 5 areas were identified as areas needed to be stronger and prioritized, which includes improved case detection, resiliency of data flow across health sectors, having congruent statistics across different levels, and improving quality of the supervision along with structured field investigation and strengthening historical contact tracing. Now, I would like to invite my colleague, Dr. Mudahara, to elaborate further on the tools we have developed at RDHS Colombo. Thank you. So, after prioritizing the needs, we actually came up with different innovative approaches at the Colombo RDHS level to strengthen the literacy management. So, one such intervention was preparation of a monthly summary return. So, as you can see in figure 2, the monthly return summary consisted of 2 components. One was to get the activities which were done at the dermatology clinic, which belongs to Colombo RDHS area, and the other component contains the consolidated data from relevant MOH areas. So this ensures all hospital-indicated cases are shared with the respective MOH areas. The report was submitted monthly to the NCSS campaign through official channels. The next initiative which was done at the Colombo RDHS was the development of the literacy master sheet. As you can see in figure 3, this shows the literacy master sheet for all 18 residential MOH areas in the Colombo district, and figure 4 shows one sheet of specific MOH, that is MOH Ecuadoriana, where we have different columns, where the first few columns of the sheet are being updated from the district level when the IPS is received at the district, while the latter columns are updated by the MOH once they do the field activity. So, this shared access to the district and MOH team update records in real time. This enables longitudinal tracking of cases and contact tracing. The district team also regularly carries this data with the NCSS campaign national database to ensure completeness. The next initiative which was done at the Colombo RDHS was to develop structured templates for supervision and field investigation. From the anti-leprosy campaign, there were guidelines on how to do field investigations and supervision. We did not have specific tools for child investigation and MOH supervision. So from the Colombo RDHS, we prepared a template to do child investigation and field level literacy supervision. As you can see in figure 5, this shows the child field investigation form which is being utilized at the Colombo RDHS currently. This ensured uniform data collection and documentation, and the completed forms are shared with relevant stakeholders at all levels. The figure 6 shows the MOH supervision form which is being utilized while doing supervisory activities at MOH level. Moving on to historical contact tracing, at Colombo RDHS, we thought of strengthening the historical contact tracing by tracing the cases from 2016 to 2020. So the cases were compiled at the district and were organized according to MOH area, and the cases, names of the patients and contact details and addresses were shared to the MOHs, and the data were embedded in the same master sheet which we are using to update the current leprosy cases. As you can see in figure 7, the historical contact for each year is being updated in the tabs along with the leprosy cases for the current year, as you can see. So this access covers household and social contact with defined screening targets for MOH area. The progress tracks regularly to ensure comprehensive follow-up. Moving on to the results, after implementation of these innovative approaches, we were able to compile monthly summary for each month in the year 2025 and forward them to anti-leprosy campaign. This has markedly improved the coordination between curative services and MOH field teams and has ensured that the national and district statistics are similar. With regard to leprosy master sheet, this has regularly been updated and been accessible at both levels, ensuring data consistency. Structured templates which were developed for supervision and field investigation have standardized the documentation process at the district level, ensuring uniformity and completeness in recording clinical, social and environmental factors. As of 20th October, 8 child leprosy cases out of the 11 cases which has been reported to Colombo district have been investigated using this format, and it has also facilitated the identification of potential sources of infection and strengthened collaboration between district teams and the anti-leprosy campaign. With regard to historical contact tracing, we have been able to identify 1,115 index patients for historical contact tracing, with tracing activities now implemented across all MOH areas. Within just 1 month of its rollout, nearly 100 index patients were traced and 300 contacts were identified. When we compare to the previous year, the number of historical contacts that can be potentially traced and screened by the end of this year is expected to be notably higher, which underscores the effectiveness of this new approach. In conclusion, early evidence shows the interventions which were introduced in the Colombo RDHS, including the preparation of a monthly summary return, development of a leprosy master sheet, development of a structured template for supervision and field investigation, and strengthening of historical contact tracing are effective in strengthening leprosy service delivery. Also, coordinated efforts with MOH supervisory officers improved case detection, data continuity, supervision, data alignment, and case investigation. As a way forward to sustain the progress, it will require ongoing capacity building, evaluation, and system integration. Thank you.
Manzoor and Dr. Idris for your wonderful presentations. Actually, it will give the guidelines to other districts also to how to implement the activities with close monitoring and organization. Our next presenter is Dr. Ibolika Amal Raj. She is from Betiklo. She is a medical officer attached to the RDHS of Betiklo. And she will talk about story of stones and steps in leprosy. Over to you, Doctor.
Good afternoon, everyone, dear distinguished guests and our esteemed audience. This is Lubujita Kamal Raj from representing RDHS Betiklo. So this is the story of stones and steps, which I would like to start about the famous stones which already laid long ago in Betiklo district. That is our Mount Eagle Hospital, a well-renowned hospital. It's an island. It's It carries 99 acres, and it was established in 1910 and actually started the treatment in 1921. It had long before even the MDT was started, and now the buildings, everything is still there. We usually visit there with a lot of peacocks and snakes. So that was long before the first stone was laid. And regarding Batticaloa, as the time is very short, I'll quickly run through. According to the statistics last year, Batticaloa has the second highest number of adult cases and the child cases. Therefore, we had to think out of the box to introduce some of the innovative methods to concentrate on the new leprosy patients and the patients already diagnosed with leprosy, including the child cases and grade 2 deformities and the defaulters, of course, and about the stigma reduction and community awareness. So, first of all, I would like to talk about our database. The database which we have collected, the accurate database which we have collected for 10 years from 2014 to 2024 up to now, which includes, apart from the basic details of the patient, we have accurately collected when the patient has started the treatment, when they have stopped. So until now it's been updated. It was not a easy task with our team actually. The anti-leprosy unit all the staff have struggled. So they have collected all the data with this. As you can see, the yellow is like a traffic light. It's like a blue, yellow, and the red. So the blue means they have missed for 1 month, and yellow means there's a risk of becoming a defaulter, and the red means they have already became a defaulter. So with this database, it's really helpful for us to trace the patients and to inform the MOHs about the treatment interrupters, and of course for the contact tracing and to trace out. And the next one is the accurate GPS mapping. Of course, we have the GPS for few years, but now we are developing last 10 years. Now we have completed for last 5 years for few MOHs. With the help of this, it actually helps for the contact tracing and the historical contact tracing and to trace out the defaulters. And with all these accurate databases, we have achieved actually a tiny milestone of defaulter tracing. As you can see, the number of defaulter years from 2015 to 2024, and from 24 last November to up to now, we have successfully restarted 46 patients in leprosy, and some patients are there, we have already traced them, and some patients are yet to be reviewed. So the database actually helps us, and this is another database for the defaulters from 2014 until 2025 we have the whole list of defaulters. Now we are on the process of tracing more. And as I said earlier, the historical context survey already we have started, and apart from the hard copy what we have in our office, we have a soft copy as well. Each MOHs are doing the historical context survey and they are updating it, and we are in a form of we can access it through the central level. And the contact tracing leprosy card. We have introduced a tiny small card. It's like a size of a national identity card of Sri Lanka, which the patients the contacts can keep inside the purse. Apart from the basic details of the patient, it has the years. That means every year the PHI or MOH, the contact should be initially visited once, and then after 1 year, then yearly. So for that, we have the small card as it's a camel area, it's been typed in camel. It is mentioned that patient should keep the card until the last visit of the PHI. With this, the contact tracing card, we have given around 46 cards in an MOH. Among that, 2 patients became positive. And another one is introducing the counselor, a psychiatric counselor under the guidance of consultant psychiatrist has been attached to the anti-leprosy unit. So he provides the family counseling and health education and the needful things. So this is a picture of he's doing the family counseling for the child leprosy cases. He is available in each leprosy clinic, and he is attached to our unit. And I would like to say during this he has referred few cases, and among that 2 became positive, and few defaulters have returned to the treatment after his counseling, because in Batticaloa usually like we have false myths and false messages and lack of awareness, especially religious myths and all. Patients don't come once they come across, once they think that the symptoms are better, so they don't come. For those things, we use this counselor. Now, with all these activities from per clinic, per leprosy clinic, the patients have improved from 10 to 45. And this is our leprosy helpline and help desk. We have a helpline. Patient can call, talk, or WhatsApp. I can talk about it later because I have another presentation tomorrow, so I can elaborate it. I'll quickly go through. So with the help of anti-leprosy campaign, which we have successfully opened up the leprosy help desk. So apart from the anti-leprosy unit, the counselor is also attached to the leprosy help desk. And regarding the stakeholder, regarding the community awareness, we have done so many awareness programs, which I would like to mention the most is the DS Office awareness program. We have completed all 14 DS divisions of the in Batticaloa district. We have completed, including the Grama Nilaharis and social service officers, which they have the close connections with the patient. Talking about the Grama Nilaharis, actually they are helping us a lot in tracing the defaulters, especially the people who have migrated from district to district or to separate addresses. It was really helpful for us, and we have conducted some TOD, training the trainer sessions in zonal education department. I have done an awareness program for the whole Batticaloa district zone principals and the physical education teachers. So they now in turn, they are doing the awareness in their respective schools. And talking about the education department, because we are having, as I have mentioned, second highest number of child leprosy cases in Batticaloa, we have conducted some other competitions as well. So apart from the normal awareness, we have conducted the art competition, which at the end, around 350 drawings we got. It's amazing. The students have actively participated, and we have arranged exhibition as well, and the essay competitions and the quiz competitions with the help of the medical faculty. They are also working with us. So involving the stakeholders actually helped us a lot. And talking about the religious leaders, in some part of Batticaloa, the normal population people, they don't listen to us. How much we are doing the awareness, they kind of neglection, fearness. So we try to approach them through the religious leaders. This is the program which I have done in Karthankudi area with the religious leaders. We have given the awareness message. Now they have included only 3-4 minutes awareness in their Friday bayan. Now the compliance is, we can see the improvement of the compliance. And capacity building programs for all the PHIs and PHMs, of course, it's a routine we have to do. But I have included the public health midwives since more than the PHIs, the public health midwives are the close to the village people, especially the family. So after the capacity building, I have included the PHMs. So now they are doing the awareness and the screening programs during the antenatal clinic, and of course during the home visit, they have a good chance to do the screening. And regarding this capacity building program, apart from the dermatologist and consultant psychiatrist lectures, normal capacity building, we have included the real patient. Long back as doctors, we had our vivas with real patients. Like that, with the help of Leprosy People Association, we got down few real leprosy patients. We got trained, and the whole audience was divided into small groups. And they have given, each group was given real patients. We allowed them to talk, examine, and try to communicate to send them to the hospital, dermatology to them, which gives them the real field experience. So these sessions were monitored by the consultant, dermatologist, the consultant psychiatrist, and they have corrected them. And as a part of the community awareness, we had a massive leprosy walk. That is, I would like to mention because all the stakeholders have participated in that. And another program which we have centered about the She with Leprosy. That is a female-centered leprosy program, which we have mainly focused on the female leprosy patients. They have so many social issues, legal issues, and psychological issues. We had the sessions with the consultant psychiatrist, and legal side, we had lawyers' input, the professional lawyers' input, and an organization which works for the female. Now the lawyer and the Women's Association is being attached to our leprosy desk. If any female approaches our desk, we are directing them for the support. And that's it. Thank you so much. This is our mission. And talking about this picture, this I got it down from a god fort. When I visited there, it's a god. They praise this god for the Avalokita Deva. So they pray to get rid of the leprosy. So just felt a bit sentiment to put it here. So thank you so much.
Thank you very much, Dr. Kamal Raj, for that interesting lecture. Next, we have Dr. Chimpa Jayasinghe, Consultant Community Physician and Regional Epidemiologist, RVHS Office, Polonnaruwa, to talk to us about the multifaceted approach for prevention and control of leprosy in the Polonnaruwa district. Over to you, Dr. Jayasinghe.
I'm going to talk on how we achieved our control activities in Polonnaruwa district. Can you please move? So as you all know, these are the things what we have to do to prevent and control of leprosy in new case detection, diagnosis, treatment and case management, disability prevention, rehab, stigma reduction, surveillance, data management and mapping. All these things we have to do to control leprosy. So what we have done to strengthen the new case detection, we have done capacity building, awareness, ring surveys, house-to-house surveys, contact screening, historical surveys, and coupled with our screening services with other public health screening services like school medical inspection, chronic kidney disease screening program, health lifestyle clinic, and leishmaniasis active surveillance activities. So, in capacity building workshops, we didn't miss any category of the health staff. We build their capacity in all medical officers, MOHs, AMOs, including Ayurveda doctors, medical students, nurses, pharmacists, dispensers, MLTs, PHLTs, health entomological officers, public health field officers, SPHIs, PHIs, PHNS, including SKSs and dengue assistants. We build their capacity to diagnose leprosy. In any case, when they are working in the field, they might find any patients. So we train all these people in healthcare sector. These are some photos of these training sessions. Then we did an awareness program as usual, but we didn't miss any community in this case. We aware all the school principals, teachers, school pupils, mother support groups, preschool teachers, government officers, funeral welfare societies, Govis committees, strike forces, OPD attendant clinic patients, and other training schools, VTA, NITA teacher training colleges, sand collectors, and three-wheel drivers. We aware all these categories of people in the community. These are some photos of these activities. Then we expand the treatment and diagnosis facilities. We have one teaching hospital in Polonnaruwa district and one base hospital with a consultant dermatologist. Attached to Madiragiri Base Hospital, there is one consultant dermatologist, but we expand the services to BH Hinguragoda and DH Bakamuna to cover the area of these two areas. And teaching hospital Polonnaruwa, there is one dermatologist. He is very busy with all the activities, but he used to visit Velikanda, Siripura and Arnakamila MOH offices and do like a satellite clinic. Where we refer this historical, what we screen in the historical survey, we used to refer these patients to this MOH area. So last year we expanded these services. Then these things we already done, disability prevention and rehab. These things we supply through the anti-leprosy campaign and from some NGOs also. They do and they supply these things to the affected patients. Then other supports, mainly to the non-governmental organizations. They support a lot. FAMED and the KKM, they support a lot for these patients to upgrade their economic levels and their welfare services. They do a lot of work. Some of these things I mentioned, toilet construction, housing construction, water supply facilities, supply of school bags and other stationeries for affected families of school children of the affected families, and some income generation activities like self-employment things for these affected families. Some of the patients are supported with transport facilities to the hospital to go to the clinic for these patients. These are some of these things, new toilets construction, houses construction and some of the water projects. Then these are some self-employment things, mainly supported by FAMED and KKM. These are also some photographs of those activities. Then special events what we have organized in last few years, art competition for school children and street drama. Then our dengue, there is already dengue meeting in the district to conduct our discuss our communicable disease activities. We combined our leptospirosis, leprosy and leishmaniasis things with this dengue meeting. So there is not a separate meeting now. All these things we discuss in the same place. These are some photos of the street drama and art competition by school children. And we did some award ceremony for this art, after the art competition, and some already we do some posters in the rural areas and as well as some public places. So we went for the most rural areas and aware these people through posters. Then I saw already some of the district people already done. We compiled all the data, all the leprosy patients since 2011, and we prepared a master sheet and categorized all the patients according to the PHI areas of the MOH area. Now we have then redistributed all the list of their own patients to all the PHIs. And now they are doing historical surveys and screening and contact tracing easily because they have their own list of patients. Because these PHIs are changing and MOHs are changing, so we again compile and make a master database and did according to the PHI area. So now we can monitor all these things. This is one of the data sheet according to the PHI areas. Once we complete the historical survey in yearly, we can complete this activity in future. Then again we are maintaining a map of each MOH areas according to the Grama Niladhara division. We must rate when there are more than 6 cases, 1 to 5 cases orange, and if there are no cases, we mark it as a green. Then we can monitor all these things according to the risk areas and the case density. We can monitor all these things according to this static light thing. Then last year we started this new innovation thing. Our malaria team, this is anti-malaria campaign, they have a regional malaria team. There's a huge human resources are there. Also huge, they have a lot of work, surveillance activities going on. But still all the malaria eliminated, we have a lot of work there. But once now they are doing the leishmaniasis survey and control activities in the field. So our leprosy activities also we combine with this field activities. They are doing active leishmaniasis surveillance in the field. Maybe 2 to 3 days per month they are doing house-to-house survey. So when they see the leprosy patients, they usually refer to these patients to the dermatology clinic. Then again, yet to start, we already done the ground work for the chronic wound surveillance. There is a vascular surgeon in the National Kidney Hospital in Polonnaruwa already discussed to do the wound surveillance for leishmaniasis and leprosy. This is the malaria team. They are doing a lot of work in the field, so we combine, coupled with our leprosy surveillance with this team. Then this is not like exponential prediction. What we expect according to the public health knowledge, we expect next 2 years we are expecting more cases because because of COVID era, our detection rates were low in our district. Now it's going up. Maybe next 2 years we are expecting more cases, and then maybe in 2030 like this we can reach our elimination things in the future. So although I presented, this is not my work, this is a lot of teamwork, and during last 5 to 6 years done a lot of work. So I have to acknowledge all the provincial directors in the North Central Province, all the RDHs in the Polonnaruwa district, all the dermatologists have done marvelous work. Even now, both of them are helping us in a extraordinary way. They are supporting for us for our work. Then all the BHI leprosy, so the RVs in previous and MOIS, MOIS, SCHS, CHIs were working hard to reach this achievement. Then all the hospital staff and PARAMED and the KKM, although it's I may mention in the last but not least, they have done a marvelous work for us, supported very well, and funding sources, all the funds delivered to us without any hesitation, and done a lot of work, and they were helping us for our staff and for the community also. So thank you for both the organizations are here. I think I would like to thank them again for supporting us for this all work. Thank you.
Thank you, Dr. Sinta, for your presentation. Actually, in our health system, the mainly implementation is with the district level. Actually, thanks for your presentation. You have shown the impact of the combined activities to gain more cases. Thank you. Our next presenter is Dr. Amila Chandasiri. He is a consultant community physician of Galle district, and his topic is dashboard monitoring of leprosy activities in Galle district. Over to you, Amila.
Very good noon. Thank you for the introduction. I'm making this presentation on behalf of the team Galle RBHS. in this era, the data visualization has become very important in public health programs as it guides us to achieve our objectives efficiently. You know, as public health officials, we spend a lot of time and we put great effort on collecting data and recording data. But at district levels and provincial levels, that we need to seriously look back how much we utilize this data for action. So this data visualization enables us to utilize the data for action. And there are a lot of digital applications has enabled us to visualize data while transforming complex data into clear visual formats such as charts, graphs, maps, which make them to interpret this data more accurately. The dashboard is one of that digital tool which is increasingly being used to visualize data. So this presentation describes how we use the leprosy dashboard in guiding disease control activities at the district level. I have a little surprise for you. The creator of this dashboard is in the audience right now, not anywhere else. In the front row, Dr. Prasad Ranavira, the former director anti-leprosy campaign and the current RDHS GAUL, pioneered this dashboard. And when he was appointed as the RDHS GAUL, he insisted us to make use of it. So that is how we get into this, and we started using this dashboard to focus and strengthen our disease control activities. So this is the output we see in the dashboard, and this is the input of this dashboard, the spreadsheet where we record, insert our data. As I told you before, it is not about creating a dashboard or entering data. What matters is how smart we get outputs and interpret that and to transform that into action. So this dashboard enables the district team to visualize and monitor real-time data about leprosy, and also this provides us an interactive platform to track trends and enable timely and evidence-based decision making. We could easily visualize MOH-wise data and have an in-depth analysis about disease epidemiology and trends. So as you noted in the previous slide, so you can set different ranges, different epidemiological variables, and you can get outputs accordingly. And how we use this dashboard for effective disease control and strengthening existing programs. We use this to identify high-risk MOH areas and target control activities with more strength. To understand the high-risk age categories while determining prevalence of breakthrough deformity, and also to understand trends over a longer period of time. You know that leprosy is a disease. It is not like dengue, it is not like leptospirosis. You have to look at the the trends over a longer period. And this is how we generated the different outputs. So you can see how it shows us the cumulative numbers, and also you can get the disaggregated data by different years, and then you can clearly see how the disease, the trend has been changed in different MOH areas, and also again disaggregated by the age, adult cases by different MOH areas and how it changes over time, and child cases in different MOH areas and how it changes over time. So you can get all these outputs from this dashboard, and then this prompted us to revamp our control approaches by conducting focused surveys and case detection, and we clearly observe that there are more cases in the coastal MOH areas, and we focus more program to those areas. And we could also conduct targeted awareness programs, and we noted a very significant trend, that is, a higher disease burden was noted among young and middle-aged economically active population, and programs were planned. Actually, we already initiated focusing work settings like BOI zone, Koggala. And this is just an example how we set the age range, and then it tells you the particular case numbers, again disaggregated by deformity level and also disaggregated by classification within a particular time period. So you can further divide this into MOH area, MOH levels. And in my previous presentation, Dr. Chinta also showed the importance of the signal light maps. So we are also using the signal light maps, and you can see how it changed. Now we get more and more greener areas in Galle district, which we are happy to see, and we want to further enhance these green areas. And the signal light maps in leprosy is a visual tool to monitor and evaluate the performance of leprosy control activities at different administrative levels. This tool helps managers quickly identify areas needing support, set targets, prioritize intervention, and ensure effective leprosy control. And this is our spot map. So this clearly shows how the disease, the cases has been changed, the numbers has been changed over past few years. And finally, the lessons learned and take-home message. The generous IT veterans like Dr. Prasad can build digital tools, but what matters is how these are utilized by provincial and district level public health authorities. So I talk loudly. So please use this. And dashboards can be effectively used to strengthen leprosy control activities at district level. It's important to interpret dashboards, outputs, and strategically use that for prevention and control activities. And my acknowledgement goes to Dr. Prasad Ranavir, the former director ALC and current RDHS Galle, and regional epidemiologist Galle, the current Dr. Veena, and also the former regional epidemiologist Dr. Eranda, and the leprosy PHI, the current and past PHIs, and also the consultant dermatologists, all the MOHs and PHIs of Galle district. This achievement is not made by myself or Dr. Prasad. This was a team effort, and as a team, we utilize the data generated by this dashboard, and I invite you to get on with this visualization technologies and strengthen your control activities. Thank you.
Thank you very much, Dr. Sangasiri. Now's the time I'd like to request the audience to ask any questions or queries they have. Are there any questions from any of the presenters of this session? Yes. Can we have a mic?
Thank you very much. My name is Paul Saunderson. Just visiting to work on the strategic plan. One thing that confused me in two of the presentations at least was the use of this traffic light, red, green, and yellow. And I'm not sure if there's a clear definition of what those mean, because the LEMT also uses a traffic light system. But if we all have different definitions of what green means and what yellow means and what red means, it will just create confusion. Because as far as I can understand, they're not the same definition in all these different maps. Would anybody like to explain that?
system introduced last year, actually 2 years ago. Actually, Dr. Indira Mahavita, and she was a guided and as Dr. Vivekal named in his presentation, we used our earlier data from year 2001 as a baseline and then start matching with the division secretary level, not the district level. Then that helped to identify the high risk areas. Because we had a limited resources. Therefore, we used our resources at some areas, you may say, the green areas. The green areas no need to go for the expensive school programs. There are no childcare like that. Then we concentrated our team, actually, Dr. Dilini, and the team, we concentrate our activities based on the maps color, the traffic light. It was very successful, and actually we could detect the more cases because we could target our limited resources to these high red zones like that. That's the way actually we target our activities.
I think we have a question over there. I think, thank you, Dr. Paul, for asking that question. So, to give you an explanation, I think during 2023, we used LENT criteria for the traffic light. I think that's what Prasad was trying to say. All the red, green, and yellow, that map was LENT. But at the regional level, Dr. Chinta, I think, presented that's the incident, just the number of cases mapped for them to act. So they know which areas. That I think everywhere in the RDSS officers, they can use that. LENT criteria, we usually comply with at national level. I think Dr. Prasad, the goal.
I think the last presentation, the goal map has used LENT. That's how they got the serial map. But I was not there when Dr. Chinta presented, but I think that is what Supunis is.
So those are for two different purposes. One is for district people to act. I think we have to come up with a uniform method, but the LENT we do have for Gaul and all the other areas. We have already done that, I think, for the other areas. That clarifies your doubt? Yeah. Can I make a comment? Sure.
No, that clarifies, but I think everybody should be clear which system they are using. Otherwise, it is confusing. And the traffic light system is very good because it's easy to understand. But if you use different numbers in it, then that's more confusing. So it's certainly a very good system, but we need to be clear what you're using.
And I would like to just add one point, and actually that as Dr. Supun clearly mentioned that what the traffic light map presented by Dr. Chinta and by me was actually for two different purposes. So at the district level, as Dr. Chinta is also a district community physician, and at district level that we can have a bird's eye view over all the MOHs and also over a longer period of to identify a trend and to which MOH areas that we should pay more attention. In Dr. Chinta's map that she presented, I think inside MOH area, and how within MOH area that at a cross section, yes. So I think we have to use both maps, both aspects, at two different points of the control. Thank you.
thank you so much for the presenters here. I think this exemplifies what we need at this point of time. What decentralized activities mean and how they can actually build the momentum for the country itself. So everything, please continue to innovate at district levels. You've seen such brilliant examples of what is being done in Gaul, in Colombo, and Batticaloa district, whether it is with counseling, whether it is with marginalized populations like the Gypsy community, the digital tools that you are using. So there's nothing etched in stone. I think it's important to interpret them, as you rightly mentioned, to interpret them and to use it for the good of the community. And then also about the helpline that you mentioned. So just wanted to congratulate on all the endeavors that are being taken at the district level. Thank you so much.
Can I make a comment, please?
Any more questions?
Yeah. Thank you, Chair. I am Brahmaraju, working now with Satyanarayana Foundation. I just got two comments. One for the presentation on leaving no one behind, inclusion of marginalized population, Dr. Niluka. I think it's an excellent presentation. But this is something world over we would like to see a clear story how people who are migrating or monitored or surveillance systems are established. I think there are a few people here in this room who are struggling to develop national strategic plan. I think this is a good food for thought for those people, including myself. And we really need to know greater story on that. Something very clearly touched is that recognizing the individual who has successfully completed treatment. There is something put the champion around, and these are the basis for the WHO studies of people-centric approaches. Maybe we would like to know more about this before we complete our exercise along with Paul Sondergaard in developing the national strategic plan. But I have one question for the presentation on the dashboard. Excellent. I know Dr. Prasad's innovations from time being I've been working with over a period. At one point, I also recognize how you use input to bring out output and fill out the prompt for action. One thing I'm not able to understand is you mentioned that it is helping to understand high-risk age groups for developing visibility. This is something much more in detail if you can explain, but it will also help us. Everybody is looking at how the patients are placed at different at-risk for developing visibility. Before OEM is used, I think there's something we are forgetting is zero visibility. Even before zero child cases, the global legacy target is zero visibility among children. So I think this is a very good point. If you can kindly elaborate how this dashboard can help in identifying high risk for children in developing disability. Thank you.
Actually, thank you very much. I think these maps used to identify the high-risk areas. We can't achieve the elimination targets at a country-wise at once. Even district-wise difficult. Then we go down to one step down and the division secretary level. And with that, we could have gone further, but the GM division level, but the people movements are very frequent between the districts, therefore we didn't go to that level. And with mapping, also GIS mapping within the division level helps to target our activities. As I said, we have limited activities. The other thing is the chronic disease. Therefore, according to the traffic light system, even though we detect all child cases next year, it will take another 18 years to get the certification. That's 5 years zero child cases, then 3 years adult cases, then both zero for 10 years. That means 18 years. Therefore, I think this model is a very strong model. So earlier, as Dr. Vivek said, earlier it was 1 per 10,000. Yeah, better in that.
I think Dr. Pemaraj's question was about high-risk age groups. So in this database, we have the age of each patient, and actually we have done this further disaggregated analysis, and we are going to present that in our posters today. So actually we could go into this same database, this disaggregation, we can take a separate group of, if you talk about children less than 15-year-olds, and then you get the disability grade. We have gone a little bit further, not only with this database, and we have actually taken out, especially for children, we could go down to the level of whether that was numbness or whether that was grade 2 disability as where it was. To that level we could go down using this database, but not with this dashboard only. But the database contains all this data which can be actually utilized.
Thank you so much, Dr. Imran. Thank you.
And I would like to add one point that I hope you noted that in one of the slides I showed that when we set the age range to 18 to 50, over the last 15 years, there were 1,000 plus grade 2 disability cases and 3,700 grade 1 disability cases. So that means a huge number, and that shows a very clear justification on why we should pay more attention on leprosy.
Thank you so much. This is also what I wanted to hear. Grade 1 to grade 2, and also Dr. Indra is mentioning about putting up other factors, confounding factors, to see the disability grading. This information is really helpful to include into the NSP so that we can meet zero disability score and then take it forward to zero. Thank you so much. Very, very innovative. Hello, my name is Jaideep Mahan. I am from Bangladesh. Actually, I'm here with a guest from Sasakawa Health Foundation. So I'm here about your program, especially dermatologists supporting the program. So how do they report, or how do you collect a report from them the cases diagnosed by dermatologists?
Sorry, can you repeat your question?
Especially the dermatologists, supporting leprosy cases, identify new cases. So how you collect report, or is there any reporting system? They report into the local center, or the staff are collecting report how many new cases are being diagnosed by the dermatologist?
Leprosy is a notifiable disease in our country. It's mandatory to be notified, and we have a separate reporting system. So each patient who is diagnosed is reported, and in any way patient is suspected, again we do a surveillance system, so we have to check their contacts as well. It's done both in primary care, and in addition, at most dermatology clinics, clinicians also get down their patients to check on it, but it's primarily done as a preventive measure as well. Is that what you are? Thank you. I think now we are running short of time, so trying to conclude the session.
Thank you very much for all the presentations and presenters for their wonderful presentations. This will in the audience, there are most of the regional directors and provincial directors are in the audience. Therefore, it will give some guidance to them to strengthen their activities in their district. Thank you. We conclude the session now.
Very insightful session there. We the presentation of best practices and innovative approaches in the different districts. Very informative, thank you very much. We have some tokens of appreciation to give all our speakers and the chairs. Could I invite Dr. Prasad Ranavira to present this token to Dr. Lubojita Kamaraj. Dr. Prasad will also present to Dr. Muthuhara Mansoor and Dr. Rekhanjali Edri Singha. Thank you, Dr. Prasad. I would like to invite Dr. Rasaratna Muraleeswaran, RDH Sabbatical, to please come onto the stage to make his next presentation. In recognition of the work done, Dr. Nilufa Gunatilaka, and to that's to Dr. Nilufa Gunatilaka. And Dr. Amila Chandrasiri. We say thank you to Dr. Rasaratnam, and I'd like to invite the chair of this session, Dr. Chaturarya Sirivardhana, to present to our final panelist, Dr. Shilpa Jayasinghe. Thank you to our chairs, thank you to the panelists, and thank you everyone for listening so attentively. We want to also make a presentation to our co-chair and the chair. So I'd like to invite the acting director of the anti-leprosy campaign, Dr. Yasuma Veerasekara, to do the honors for our chair and co-chair. Chairing that session was Dr. Chaturarya Sirivardhana. And co-chair, Dr. Prasad Ranavira. Thank you to Dr. Asama also, and to everyone here. Ladies and gentlemen, you may step down. We are breaking for lunch. We are just about